So we can have everyone come up now for a few case presentations. I'll show one quickly here. We don't have too much time, but I think there's two others. So I'll start. This is a 49-year-old nurse with chronic neck pain, worsening bilateral radicular symptoms, failed conservative measures, decreased sensation and strength, and is spondylotic at C5-6 and C6-7. And as opposed to the other case I showed earlier, the disc pathology above is not adjacent at C4-5, it's at C3-4. So it begs the question, I think it's generally considered poor form to do a skip fusion because of the intervening normal disc breaking down so rapidly. So anyone have any thoughts on this case?
Do you have any axials at the C3-4 level?
Unfortunately, I don't, but I can tell you that C3-4 is actually more stenotic than the others. It's central, it's a soft disc.
Disc replacement 5, 6, 6, 7, fusion 3, 4.
So that's interesting. With 5, 6, 6, 7 being more collapsed and spondylotic and C3-4 being a soft disc, why that way, not the other way?
Well, because I can get away with a two-level artificial disc at 5, 6, and 6, 7, being covered by the insurance company. Can't do 3 levels, they won't cover it. It's not that collapsed, it's about 50%. Doesn't look, especially on the MRI scan, doesn't look that collapsed. And 3-4 disc herniation and stenosis appears to be much worse than 5, 6, 6, 7, at least on your side of it.
Yeah, I think you brought up a good point. Sometimes what we do is very restricted by what the insurers are willing to authorize. I mean, you really get into, you can't do 3 levels, you can't do some hybrids, they simply won't authorize it. But this is what I chose to do, and the patient did well. So we can move on to the other couple cases I think people brought.
You know, load one of our cases. I gave you my cases. You can put those in.
Can I make a comment if there's not cases on MobiC? I have a lot of experience in MobiC, and there's probably some pitfalls associated with it. The comment was made earlier about the sloppiness of MobiC, and it is. Earlier in my own MobiC experience, I noticed a lot of the theses flexion that reduce an extension, and it could get significant. So one thing I've learned is the MobiC needs to be in the middle. You don't want it too posteriorly because that's what leads to lethesis. Also, the superior end plate needs to be slightly more posterior than the inferior portion of the disc. And when I started doing that, it took me a long time to figure that out, I stopped getting the lethesises that we saw. Because a lot of these lethesises become symptomatic. The other thing, does anybody have any comments on the dreaded C5 palsy? It sucks. I mean, it's miserable. It sucks, and I don't see it with artificial disc. I see it with fusions anteriorly. Does anybody have any comments on anything they know?
Are you talking about just based on anterior surgery? Yeah. Not posterior.
Anterior.
I don't know if this is on. I think that my comment would be I tend to agree that I see it less frequently anecdotally on my arthroplasty patients, and I think it's because we're more careful to preserve bone. And because we don't want subsidence, we're more careful to not resect as much of the uncinate. And I think, frankly, aggressive bony resection, which causes neural drift and potential tethering of the C5 root, leads, I think, to more C5 palsy, whether it's an anterior or posterior approach.
But if you have significant stenosis and spondylotic disease and you have to take it, you can't leave the spurs there because someone's going to criticize you.
Correct, but now you're selecting those more for fusion than arthroplasty, thus your lower C5 rate in arthroplasty.
Right, but any tricks on how to prevent it with fusions?
No.
Because I can't figure it out.
The difference in patient selection, and case difficulty, the ones you're not choosing for ADR probably a lot more likely to lead to the C5 than more simple cases.
I have a couple comments. They're mostly anecdotal. Number one is I asked Dan Rue whether or not he sees a difference in prevalence in a C5 palsy when he goes anterior versus posterior. And he said in his experience he's never seen an anterior C5 palsy, which I found shocking. In my own practice, it's almost equal. As I've gone back and looked at my C5 palsy patients, and they're all with fusions, it's generally patients who I tried to put a larger, taller interbody device in.
So you're distracted.
I think it's over-distracted in those particular anterior cases.
Should I distract because I want to get at least an indirect
Absolutely.
decompression. I do a wide parameter decompression because I don't want to leave any parameter stenosis because one of the theories is that's the cause of the C5 palsy post-op. If you have any parameter, I do a wide parameter decompression also. But I'm seeing it, and maybe because I have such an elderly population down in Florida.
I tend to see it in
less of the soft discs.
the older men who have really collapsed spondylotic discs, to me, are the highest risk, especially when you try to distract them. Yeah.
So I read one study that looked at it, and it was one surgeon's experience, and it was how much he felt how much he was burning in that sort of the framing at the uncovertebral joint, and that almost there was a thermal reaction. And his anecdotal response to that was to leave some of that behind and jack up the disc more to get the indirect decompression in his series of 20 whatever. He didn't. So it's like you're screwed on one end and you're screwed on the other end of this. I mean, it's just awful no matter what.
Yeah, I trained with Kevin Foley, so I called him, and he told me never put a kerosene out in the frame.
Yeah.
I mean, and I do that.
Yeah, I do that all the time.
Yeah.
I can just share you, I do a lot of work with neurosurgeons on posterior complex cervical work, and we kind of have a bit of a disagreement. My neurosurgeons partners, Praveen Mumaneni specifically and Dean Chow, they're really good at posterior cervical work, but they prefer to just avoid touching the C4-5 framing at all. And I'm almost the opposite. And Coy actually has operated with both of us. And I'm almost the opposite. Is I really get very wide in those framinotomies. And one of the things we started doing recently, and I'm not sure, I can't give you any data on it, but in terms of getting some more indirect decompression there, is we've actually been using a facet spacer, a D-track device at 4.5, sometimes at 5.6. And it's pretty early on. We've been doing that for about the past year or so, trying to get some further reduction. But my approach on it is to really blast out a lot of that facet joint. With the D-tracks, I'm not going quite as far laterally. My neurosurgery partners don't like to touch in there at all. I don't know, Coy, you've seen both. What are you doing now in Oregon?
Just decompressing enough to where a pimple fork can slide pretty easily into the framing. So somewhere between probably the two.
Yeah, we've also got this curved pen field that we slide out and make sure there's enough room there and kind of burr on top of the pen field rather than use a kerosene in there.
So some people have tried to publish on that, right, about whether or not a prophylactic foraminotomy made a difference, and at least my understanding was it didn't make much of a difference at all. So it's just one of these things that just happens. I think the one study, at least posteriorly, that I think has changed a little bit in my practice is how wide you do the laminectomy, and almost you're purposely impeding the drift back to a degree, and that showed a little bit of a difference against small numbers. I've adopted that a little bit posteriorly.
Is anybody using medication, it's like an MS medication, to help with palsy? I'm blanking on what medication it was. Nobody's using.
I'm using steroids preoperatively. This is like a darn
Yeah,
thing.
no, this was like specifically like for neuromodulation.
Like post-palsy?
No, actually giving it preoperatively to limit your post-palsy.
Okay, we can do a case. 56-year-old presents with a year of worsening neck pain. It's worse with activities. Got hand numbness, drops things occasionally, no weakness. You really have to. It's one of these myelopathy patients. You kind of have to pry their myelopathy symptoms out of them. Oh yeah, I guess I'm a little bit off when walking. I just thought I'm getting old. Those kinds of things. Or I drop things, but I have arthritis in my hands. Kind of findings. Full strength, normal balance on exam, not ataxic at all. There's his X-ray.
Great.
Anybody want to tackle that?
You gonna give us anything else? Is that it?
We'll start there.
All right.
We'll get it. I guess in the interest of time, I could just give you the MRI too, and we'll just jump to that.
Yeah, I would just say get in a car and drive to DC.
Yeah. I have a great surgeon for you, just 45 minutes from me,
That's
up
right.
in Baltimore.
I mean, so clearly there's a very focal kyphosis there at 2, 3, 4, at 5, 6, with what looks to be a chronic degenerative process. 5, 6 almost looks autofused with all this bone anteriorly, and then this compensation to try to get their head up and thinning of the cord, draping of the cord, multiple areas where there's signal change in the cord. So this is a patient where with all those signal changes, despite the relative paucity of symptoms, I think the signal change and the deformity itself argue pretty strongly for some sort of surgical treatment. And I guess I'll stop my comments there.
Yeah, I agree. My question is, are there any underlying medical issues going on here? Any sort of neuromuscular issues, Parkinson's? You said this patient's 56?
56.
So just wondering if there's something sort of leading to this that needs to be taken into consideration. But yeah, so this is one of those where you can either just focus on decompressing the cord and addressing just that, or you can try and be heroic and address the deformity as well. So you can either try and think about, am I going to just stabilize this person sort of in situ, or am I going to go in anteriorly and try and address the kyphosis that may have led to some of this? And so that's where some of the medical comorbidities and issues would come in. And also, does this person have thoracolumbar deformity that you need to sort of consider if you're going to do anything? Is there something else going on lower down that would predispose to failure of like a fusion in situ or anything like that?
Yeah, I mean, I think that's a great point. He has no significant medical comorbidities. I definitely know what you're saying, though. I've seen patients a lot with renal disease and things like that just have these really almost look like post-infection disc spaces that really are collapsed way more than you would expect, and that can lead to that. But he has no comorbidity. He does. I did do a full spine X-ray. I don't have it here. He's just got a lot of this same crap going up and down the spine, basically degenerative. Fairly flat in his lumbar spine, though clinically he stands very neutral.
And that image on the left, is that a standing lateral and extension, or is that a supine lateral? Do you know?
That is a standing.
Standing lateral. So those are FlexX standing laterals.
Yep. Yep.
And some other things you can consider are sort of the functional positions. Like if you lay him down and put him in more to extension, does he flatten out? I mean, this is an MRI, so he's been laying down for quite some time, and there's very minimal movement across that kyphotic deformity. But more functionally, thinking about the C5 palsy risk, if he's laying down for a few minutes, up to 30 minutes, Dan Rue will lay patients down and see if they start to get radicular symptoms. And then at that point that you need to, those are sort of nerves at risk if you're going to fuse them or correct the deformity. And so those are areas you might want to consider prophylactic foraminotomy or decompression in that area.
Yeah, that's a good point. I didn't think about that, looking at those symptoms that way. This guy, as you can imagine, just based on his description, when he entered the office, I mean, this was kind of shocking me that he was this bad based on what he looked like. He doesn't. I mean, and sometimes you can see patients, their head can't even get back to the if you have them lie down. This guy, you couldn't. He's compensated very well, and this was a very surprising. Other than stiffness on his range of motion, he really is not having any limitations from this, and fairly minimally symptomatic, comparatively. So, I mean, would anybody just tell him we're going to watch you? 2 months maybe of balance issues, some numbness in the hands.
If you watch him, he's 56.
Yeah.
If he was 86, exactly, great point. But 56,
So,
he's got a lot of living.
In the interest of
When he goes somewhere else, it's just worse.
yeah, that's right. In the interest of time, what would anybody do here? Would anybody go anterior, anterior, posterior only?
I mean, looking at it, Bobby, given he said he had minimal neck pain. He stands, especially neck extended. almost balanced. His T1 tilt is minimal. He's got hypokyphosis in the thoracic spine, so he's sort of compensated there. I think the imaging, his symptoms, and his stance balance would argue for a less versus more approach in terms of the deformity piece. So I think I would favor sort of a C2, inferior C2 to C6 decompression and laminectomy, and then a C2 to proximal thoracic instrumented fusion posteriorly. Thankfully, he's a thin guy, he doesn't have a big posterior fat layer.
Do you think you could just decompress him?
You look at, this is a great case to get a CT scan, first of all.
We have one, I just don't have it loaded.
He has 8% joint osteoporosis.
He does.
These patients, he's not really compensating very well. If you look at his standing lateral x-rays, lamina is right up against his occiput. And if you use him at 56 to, in that position, say, he's going to start developing a significant amount of occipital headaches, C1-2 pain, and now you've created a bigger mess because now you have a fused neck. These patients actually do extremely well when you take them anterior posterior, aggressive, you put them in a Gardner-Wells weighted traction, about 20, 30 pounds. Obviously, you got to have good neural monitoring. As you start taking down the osteophytes and using a cop to crack open the disc spaces, they open up. You'll be surprised. And you're distracting. If you look at most of their, obviously C2-3 is a little higher up, but if you look at most of their, the stenosis, it's this pincer effect where the ligamentum flavum is pinching posteriorly. So
Well, he's become hyperlordotic above the kyphosis.
right. But even
Compensating.
as you start distracting disc space, you're decompressing him indirectly, and you'd be surprised what a great correction you get. Now they have these hyperlordotic anterior cervical cages, and I have some cases you can show you that. And sometimes you end up having to take out one of the vertebrae there because there's not much left as you take out all those anterior osteophytes. But I would argue in a 56-year-old who's maximally compensated at his occiput C1 angle that this guy deserves one chance of correcting him, and I certainly would. But the key there is the weights. I think if you put them in, I actually use the Mayfield 3 prong, so I don't have to switch out the Gardner-Well tongs to the Mayfield when I go prone. But you put them in that and just leave it loose on the hinge and put about 30 pounds of traction on him. They'll do extremely well. And the fact that he can go to sleep and has minimal symptoms, he's probably tolerating stenosis pretty well, that he's not as fragile as you think, lying supine and putting him. I mean, you got to do it in an efficient manner. You can't keep him on the table forever, but I would argue that this is a good case to go anterior posterior. And I try to keep as much of the vertebrae intact and use intersegmental distraction and correction of the lordosis to maximize the lordosis, because when you start doing vertebrectomies, you lose some of your lordotic correction.
That's a great point. So who would go anterior and posterior? And who would go posterior only? So just to push it forward, I actually, your logic, Justin, is exactly what I thought. I just did a C2 to T2 posteriorly. I thought his, just positioning on table, you can see opened up a little bit even in those disc spaces. I can imagine the traction would have done a lot to that, to your point just right there. But his compression was actually in the lordotic segment of his spine. So in order to get the actual neurologic decompression, I thought he was going to have adequate drift back for that. So I really wasn't worried about it. And his overall compensation to manage the cervical-thoracic junctional deformity, I think, was very well balanced clinically. Your point about the proximal segment, is important.
Corrected him well.
Yeah.
C or C1
Yeah. So, but that is something that, how much is he going to compensate over time? He's got another, couple decades to go. So that definitely is something to watch for. I just felt uncomfortable, and this is something I struggle with myelopathy, is putting the patients through a front, back, cervical, corpectomy possible, dysphagia issues, all these kinds of things for something that they're surprised that they're even having surgery for. And that's always a tough conversation. And it's a little bit of this theme that we talked about, what the patient wants, what the patient actually needs. But I felt I was able to accomplish the majority of what we need to do just doing this. So 2 years out now, so he's got a lot of improved neck pain, a little bit of numbness in his function, doing pretty well.
I would just be concerned about the loss without anterior column support. 5 and 6. I would consider that a C5 and C6 will technically expand the cage, and then
Yeah, I think that, I mean, he's already sort of auto-arthrodesed anteriorly, and, I mean, essentially, he's got a very stiff spine, you know, in the cervical thoracic junction, so I was fairly confident that there wasn't going to be a lot of that persistent force to pull him forward. And posteriorly, I mean, he essentially, you're right about the CT scan, I didn't include it. He had essentially almost auto-arthrodesed several of those. You know, there was still some motion there, but I thought that it was going to be stable enough. But that's a great point. Yeah.
Yeah, it looks like really the only open disc there is at the 4-5 level.
Yep. So I think we're a little bit over. Yeah.